I am very glad to welcome you all to the third ISoRED webinar, Community Building in Radiation Epidemiology and Dosimetry Research webinar. As you know, this is the third webinar of the ISoRED series, and with the aims to bring together radiation researchers from all over the world to discuss the effect of ionizing radiation on humans, on epidemiology, and so on. Today, I'm very glad to announce and to present my colleagues from the Institute for Medical Research and Occupational Health from Zagreb, from Croatia. And today's webinar will be dedicated to radiation epidemiology and dosimetry in their institutes. Not to take too much time from the lectures, which will be very interesting, I would like to give the floor to Goran Gajski, the first lecturer. He's currently working at IMI as scientific associate, and his main field of interest are genetic and environmental toxicology, with special emphasis in radiation biology and human biomonitoring. He published more than 100 research papers. He's participating in different projects, engaged in many international and national projects. But you will see now one very interesting presentation about application of the backroad micronucleus cytome assay on child population exposed to sinus X-ray. Goran, I give you the floor. Please be within the time so that people can ask questions. To the audience, please, if you have question, you can raise the hand and pose the question after the lecture, or if you prefer, you can write the question inside the chat. Please, Goran.
Thank you, Željka, for this nice introduction. So I think my screen is already shared, so I can start with my presentation. But before I begin, just a few words about our institute. So the four of us are from the Institute for for Medical Research and Occupational Health in Croatia, in Zagreb, the capital. You can see our institute on the picture of the first slide. We are the second largest scientific institution in the country, and we are organized in 10 scientific and professional units, mainly covering life sciences, biomedicine, occupational medicine, but also radiation biology and dosimetry. This is our old building, and we are currently building the new facility that will make us one of the most important scientific institutions in our country. But more about our new institute and our future projects will be said in the last presentation by my colleague Ivica Prlić. So here is the title of my presentation that I will give today. It is application of the buccal micronucleus cytome assay on child population exposed to sinus X-ray. So to start with my presentation, I would just like you to know that worldwide diagnostic medical examinations are constantly on the rise. You can see that in the 90s, we have 2.4 billion diagnostic examinations, and this rose to 3.6 billion in last years, but it is constantly on the rise. It has to be pointed out that more than 350 million of these diagnostic medications is on children or on pediatric population. Here on this chart, you can see the relative frequency of different X-ray diagnostic procedures, and the chest examination is one of the most used, and the skull examination is done in the frequency of 3.2%. If we let us see how these radiological procedures are performed on children, you can see that the ratio of skull and head procedure in children is almost 20%, which is quite high. In regard to that melody, which is multidisciplinary European low-dose initiative, they set a few goals in their strategic research agenda. One is the health risk evaluation. to investigate pre-stages of cancer in any available biological samples, for example, tissues, saliva, or blood, and to identify and validate biomarkers of exposure and health effects related to cancer. Another issue is research into basic mechanism in order to determine the contribution of DNA damage or mutational processes at low doses and those rates. Let me just open the laser point, it would be easier. Okay. So what was the aim of our study? We wanted to see the frequency of genome damage before and after X-ray examination of paranasal sinuses with one of the best validated methods for evaluation of genome damage, and this is micronucleus assay. Micronucleus assay is usually done on blood cells, namely human lymphocytes. You can see one lymphocyte here, and this is one of the best validated method. The problem with this assay is that you have to draw blood. And since this is not completely invasive, but minimally invasive method of sample collection, it is not so appropriate for children, especially the youngest one. So we try to apply more less invasively collection of samples for the micronucleus assay using buccal micronucleus assay that is dealing with the cells from the buccal cavity that are non-invasively taken. Here on this picture, you can see cross-section of human buccal mucosa indicating different cell layers and cell type, and what can we see in those cells after exposure to different physical or chemical agents. For this pilot study included 20 children exposed to sinus X-ray. They come to the hospital with symptoms such as cough, rhinitis, on headache, and this was prerequisite for their X-ray. It was important that the children were not irradiated in previous 3 months before the sampling, and that they didn't get any radiation in the time frame of 2 weeks after the radiation. What is the time frame to collect buccal cells, and then they were not exposed to, were not taking antibiotics or corticosteroid that could all interfere with the DNA damage. So in our pilot population, we had 11 girls and 9 boys. Here you can see the study population characteristics. So how the whole procedure went, we did the recruitment at Srebrnjak Children's Hospital. Some of the patients, of course, didn't want to participate, or we couldn't obtain the parent approval. And for those who we did, they first filled the questionnaire with all the anthropometric data, previous radiation, usage of medication, and so on. Then we sampled the buccal cavity with a small-headed toothbrush. It is for kids. It is quite gentle procedures. Is they just need to scrape the inner cheek of their mouth, and then that toothbrush is immersed into the buccal cell buffer. You can do this with a special sticks, but for kids it is much more fun to do it with those funny kids toothbruch, then they're really cooperative. After that and before the X-ray examination, we put dosimeters, radiophotoluminescent dosimeters on several positions of the head, and children went for the X-ray examination. Some of them were lost to follow up, but another sampling of the buccal cavity was done in the time window of 14 days, when the buccal cells from the lower layers of the buccal cavity can go to the upper levels, and then they can be collected and inspected for potential genome damage. So here are the results of the dosimetry. You can see the mean results of the radiation of several positions in the head. We had in average 20 micrograys on the left supraorbital foramen, 665 micrograys at the occiput, 12 micrograys below the tongue, and 15 micrograys in front of the thyroid gland. Now let's cross to the biomarkers of DNA damage. With the buccal micronucleus assay, we can assess several DNA damage and cell damage parameters. Here on these two charts, you can see DNA damage parameters such as micronucleus frequency and nuclear buds. Micronucleus are indicative of chromosome loss and fragmentation, while nuclear buds are indicative of elimination of DNA amplification and DNA repair. And on the charts, you can see that there were no statistical differences before and after radiation, although we did observe a higher incidence of micronuclei after the X-ray radiation. Here on these charts, you can see the formation of micronuclei, and on this chart you can see how good is the correlation between the blood micronuclei and the buccal micronuclei, indicating that the buccal micronuclei could be used as well as the more validated blood micronuclei, especially in the child population. Why micronucleus assay is so important is shown on this graph, because there is likelihood of getting cancer later on in life is connected with the higher frequency of micronuclei, and since children are much younger than the adults, they have more life expectancy to develop such genome abnormalities, and as a consequence, cancer later in life. Besides micronuclei and nuclear buds, you can expect different cytogenetic defects and proliferative potential by measuring binucleated and basal cells. But as you can see on the level of these 20 children, there were no difference before and after radiation. And at the last, we were measuring different categories of cell death by condensed chromatin, karyorrhexis, pycnotic, and karyolytic cells. And you can see that only condensed chromatin was significantly higher after irradiation, indicative of early stages of apoptosis. So the formation of apoptosis occur after this radiation. And for the conclusion, I would just like to say that X-ray doses are low enough to maximize patients' safety in this kind of procedure, that the role of micronuclei as a biomarker needs confirmation, of course, in a larger studies, and these kind of studies are currently done, as well as in pediatric population, and that other tissue damage effects need more thorough research, not only human lymphocytes or the buccal cells. And with this, I would like to thank you for your attention, and just would like to thank my colleagues from the Institute Ruđer Bošković, from the Children's Hospital Srebrnjak, and of course from the Institute of Medical Research for their cooperation in this study and in this research. Thank you.
Thank you, Goran, for a very interesting lecture. I was very impressed by the number at the first slide about the number of medical examination. It's really huge. Do we have some questions? Anyone want to ask a question? Rania raised hand.
Thank you, Goran. That was a really good presentation, and I loved your slide setup as well. Do you plan on doing any correlation studies to see how DNA damage correlates in buccal cells versus blood?
For now, we in our laboratory we did not do this, but this is done in several studies. Correlation between buccal and lymphocyte, and the correlation is excellent. So the buccal micronucleus assay could be used instead of lymphocyte micronucleus assay, and this will be extremely important for the youngest population, for the children, because it is completely non-invasive.
Thank you.
Can I ask one question? Goran, do you plan to make some investigations during other procedures, for instance, computer tomography?
Yeah, this was actually our goal. We are currently looking for the financing or to some projects goal, because we will be very interesting to do on the adult population the similar study after CT scan. And since the idea is to be done on adults, then we can do in parallel lymphocyte as well as buccal micronucleus assay and get a real correlation in our study for the two assays involved.
Thank you. I have one question in chat. From Lydia Wilson. I might have missed it. Did you do any correlation between micronuclei and the dose?
Oh yeah, we did, but since these doses are really small and in the small range, we couldn't find any positive correlation between the frequency of micronuclei and received dose during the procedure. But it has to be pointed out that there were large inter-individual differences between each monitor child. So you can look results not only on the level of population, but it is worth to look at the results on the individual level as well.
One more similar question is one, do you plan to do study in children exposed to CT scan?
This was not currently the plan, but of course we are open for any such ideas.
Okay, thank you, Goran, very much. If somebody else has a question, can ask in the chat and we will forward it to Goran. And now we will move forward to the second lecture, which will be presented by Marko Gerić. Marko Gerić, who is also currently working as a scientific associate at IMI. His field of interest and work is genetic and environmental toxicology, also human biomonitoring. He's also involved in many national and international projects. He published more than 40 research papers and 3 book chapters. Today he will present a presentation about cytogenetic status of interventional radiology unit workers occupationally exposed to low-dose ionizing radiation. Marko, the virtual floor is yours.
Thank you very much. Do you see my presentation?
Yes.
Okay, great. So good morning, good afternoon, and good evening to all of you. I'm sending this little postcard from Zagreb. Hopefully we will meet one day in our lovely city. And yes, today I'm going to talk about the interventional radiology units. So let me briefly walk you through the introduction. So first of all, we need interventional radiology unit team. And those teams are usually comprised of interventional radiologists, nurses, radiology technicians, and physicists. What is specific to their job and their occupational setting is that they work in the close proximity of X-ray source. That's why they need to have heavy lead aprons that will protect them from radiation. And usually those protective equipment is, let's say, over 4 kilos weight. When we talk about these interventional radiologists, there are some interesting facts. In the last few decades, the absorbed dose per each procedure dropped 14-fold. But on the other hand, the number of such interventions has risen 10 times. So basically, all the health effects are more or less the same. And while we talk about health effects related to this occupation, we can say that roughly 60% of them report low back and neck pain, while 38% of them injure themselves with some kind of sharp objects per each year. And in relation to radiation protection, the ICRP has set the annual effective dose limit of 50 millisieverts while the 5-year cumulative dose limit is set to 100 millisieverts. Despite that, some novel reports say that around 5.5-fold more left-sided head malignancies are found in this population. Unfortunately, this is not the only case. So apart from having a larger proportion of left-handed brain tumors, these population have higher incidence of thyroid and liver cancers. And we all know that one of the major events in carcinogenesis is DNA damage and genome instability. So that is one thing we know for sure. What we are not fully aware of is how DNA will behave when exposed to low doses of ionizing radiation. That's why the Melody, as we have already heard, has issued the research strategic agenda, which has set several research priorities for the future. And one of them is investigation of low-dose radiation, so understanding basic mechanisms and evaluation of health risks. Taking all this into account, we have set up the aim of the study to conduct a biomonitoring study that investigated primary DNA damage and structural changes to chromosomes and chromatids, and we coupled it with the dosimetry and correlation of all these data. To achieve our aim, we needed to recruit the study population, so we were lucky to have all 3 interventional radiology unit teams from Zagreb. So in total, 24 people. Here you can see all their demographic characteristics, and what should be pointed out, that none of them reached or passed the ICRP limits. What is also important for the study is that we compared it with control populations, so unexposed population, and this population was equally matched with the exposed one in order to minimize the effects of possible confounders. And after performing all the analysis, we got following results. So the first thing is micronucleus test, and here we did not see any changes in frequency of micronuclei, as well as we did not see the changes in frequency of nucleoplasmic bridges. However, we did see increased frequency of nuclear buds. So nuclear buds are these bodies that these parts of DNA that is extruded from the main nuclei of the cell, and it represents the overamplified DNA. Usually those are DNA damage repair complexes, and this could also be considered as one of the initiating events in micronuclei formation. On the other hand, we also performed the comet test. Here we can see the characteristic comet-looking nuclei, and when we measured the length of these tails, we can see that exposed group had higher comet assay tails. Moreover, we also quantified the signal of the comet assay tails, which corresponds to a percentage of DNA, and we did not see any changes between these groups. I also mentioned that we tried to correlate all the results, and interestingly, the thing that correlated well was the frequency of micronuclei with years of active service. It is interesting that none of these linear models could explain the dose and the response or the effects, and that is also the case from the literature. So that we definitely need some other models to explain this dose response. And finally, what would be the relevancy of these results? So we already have seen this little picture, which we all like because it's very important. It means that the people with a low frequency of micronuclei have less risk to develop any kind of cancer. And on the other hand, the more people have, they have the higher content of DNA present in the comet's tails, the risks of overall cancer mortality increase. So taken together as all these results, I would like you to have two take-home messages. The first one would be that we definitely observe the molecular changes in population occupationally exposed to low-dose ionizing radiation, but at the same time, we need further studies to assess risks of this occupational exposure. At the end, I would like to thank all of my colleagues who were involved in this study. I would like to thank ISoRED for giving me opportunity to present my work, and of course the volunteers who decided to participate in the study. And before the very end, I would like to make one announcement. Recently, we have initiated the new investigators group within EMGS, and here, if you scan this QR code, you will get all the information. So it's intended for young scientists within the field of environmental mutagenesis and genomics. And please pass the message to your young colleagues. If you need to contact me, here is my email address. And now I would like to thank you for your attention and thank you for your patience.
Thank you, Marko, for very interesting presentation. I see one question in the chat. Thank you from Von Yin Lee. Thank you for your talk. Do you know what were the main interventional procedures?
Yes, we know that. Mostly those were cardiological procedures. So any procedures that needed surgery of a heart and cardiovascular system.
Okay, thank you. Any more questions? Maybe very nice presentation. Did you make correlation with the doses received?
Yeah.
But this was doses given by personal dosimeter. You didn't measure any additional doses.
Yeah, those were doses that we got from their personal recordings, and we didn't run any additional dosimetry. That could be the problem because according to literature, we saw that people don't wear those dosimeters. Yes. They don't wear it properly, and there are many more issues. What could be also done in order to improve dosimetry.
This could be interesting to see, to really measure during the procedure the dose to the operators, because of what you said. Many people don't wear it properly or don't wear it every time or on the same position. It would be nice for the future to correlate with the measured doses. Okay, any more questions? Great presentation from Lydia Wilson. Might be a little outside your area, but I'm curious if there is any justification for the increase in left-sided brain tumors specifically.
Yeah, of course. Sorry for that. Yes, there is one really good explanation, because the source of the X-ray is usually near the left side of their hand. So basically, that it always tends to their left side. Yeah. So it could be one of the reasons why that part of the brain is usually affected.
Mm-hmm. One more from Mohammed Abdel Halim. Were the controls other doctors or general populations? I mean, other doctors who are not exposed to radiation.
Yeah, this is a quite good suggestion. Unfortunately, no, the controls were from general populations, so those were not doctors. But yes, it would be ideal if we could have the equally matched controls that would be also the employees from the same hospitals. But unfortunately, we couldn't do that. We had some issues with getting those participants to be enrolled in the study, so it was easier for us to match them from general population.
From Robert Hayes, we will take only 1 or 2 questions. I was surprised at the small size of uncertainties predicted based on the sample size. Can you elaborate on this?
Yes, well, it has to do with the distribution of micronuclei and comet assay within each population. As we saw on earlier on Goran's presentation, those inter-individual variability is in fact quite high. But yes, when we talk about micronuclei, then we are talking about events that occur like from 1 to, let's say, 10 or 12 events per 1,000 analyzed cells. On the other hand, based on for the comet assay, we screen over 100 cells, and more or less if somebody is exposed or non-exposed, so if the genetic material is damaged or not damaged, so those distributions of occurrency of each biomarkers is pretty narrow. I hope that was the question.
Thank you. And one more was on the general, talking about general populations, are there radiation staff or patients?
No,
the control
group. No, those were like healthy people from our population. So they were not patients. They were not. They were not employees of the hospitals. So, like really general population. It is important that they were not exposed, that they didn't receive any kind of diagnostic radiation. They were not treated with any medications that could interfere the results, but we tried to match them for as much parameters as possible to reduce our outcomes to exposure to occupational exposure alone.
Okay, thank you, Marko. I will just read the last comment. Left-sided exposure of the right-handed operators, which are expected to be the majority. This is this was just a comment. Thank you, Marko, very much. It seems that it is a very hot topic, and we had a lot of questions. If you have some additional questions, you can write directly to Marko, and they put all the information also in the chat about the Comet Assay Working Group and also to this EMGS group. So thank you once again. Thank you once again. And now we move forward to a little bit different direction to let's say a bit of maybe dosimetry. The next presenter will be Luka Pavelić. He's a PhD student at IMI, at Unit for Radiation Dosimetry and Radiobiology, and his main interests are development of ionizing radiation detectors for dosimetry and medical imaging, nuclear instrumentation, and use of Monte Carlo simulation methods to describe real exposure situations of pulse electromagnetic radiations. Today he will present electronic dosimetry detector system for time-resolved measurements of pulse ionizing radiation fields. Luka, the floor is yours.
Thank you, Željka, for the introduction. Can you see the presentation?
Yes.
Yeah, okay. So I will start with motivation for this research. Here in the table, there is, I have collected response times for each instrument that measures dose rate, H*10 dose rate. So you can see in the middle that mostly these instruments take more than several seconds to respond and to obtain some useful measurement. Here at this graph, there is each line shows a separate measurement of transient response. That is actually the output from this detector when exposed to a sudden exposure to the cesium-137. You can see that it takes about almost 10 seconds for values to stabilize and to obtain an accurate reading. But most of medical X-ray exposures are in milliseconds range, especially those in pulse fields. So it's really hard to measure dose rate accurately with these kinds of instruments. So we wanted to try to develop some new solution to this problem, and we figured that all of these detectors have really long time constants. I do not have time to go into details why these time constants are long, but we can look at the coefficient of variation, because these detections of individual events can be best described with Poisson distribution. And coefficient of variation is reversely proportional to detector sensitivity to the time constant of the detector and dose rate. We can't change the dose rate because it's a parameter of external field that we are trying to measure. The time constant is the thing that we are trying to decrease, and we can only boost detector sensitivity. So we tried to make and design detector based on scintillation crystal. Our detector is composed of sodium iodine doped with thallium and connected to the silicon photomultiplier. The whole assembly was enclosed in 3D printed enclosure, and the signal from the detector was fed to the fast amplifier, and from there to pulse digitizer. And the pulse digitizer was actually a high memory depth digital oscilloscope, from where the data was saved to the PC for the offline analysis. We were very interested to research the detector energy response, because it's one of the really important things for dosimetric measurements. We were expecting that this detector should have some kind of energy compensation, and we had an idea to develop an energy compensation filter that would somehow flatten the response of the detector. So first, the Monte Carlo simulations that were used, their code was validated through the calculation of H*10 dose per fluence. Here on the left side, you can see the expected results from another research group. And at the right side, you can see our results. The green line at the graph is showing those H*10 dose per fluence from the ICRP 74 table data, and the red line was our calculation. As expected, these lines are showing really good fit, and up to 4 mega electron volts, where they are starting to separate, and that's okay. This was expected because the ICRP 74 data points were obtained through the different calculation method employing Kerma approximation, and our results are computed by using full energy transport that's more accurate. Here are the results of our detector energy response. These values are normalized to the cesium 137, and dashed dotted lines present an IAC limits. You can see a very high peak at around 100 keVs that needs to be flattened. So by employing our energy compensation filter, we were able to flatten this response within those IAC limits, where the best results were obtained by using lead filter, thickness of 2 millimeters, and a circular hole in the middle of 4 millimeters. This is presented as the blue line in the middle. Here are results from some different geometries and different filter materials. And you can see data points for Wolfram and iron filters. We also found it interesting to investigate filter attenuation curves, because at the areas where detector response naturally was not too high, we wanted to influence it as less as possible. So for those areas, especially for high energy, we wanted to have attenuation curves as close to 1 as possible. And as we can see here, for these lead filters, that is the case. The worst performing here was the Wolfram filter. Here you can see the picture of the detector. From the right side, is assembled the detector module connected to the amplifier board, from which the signal is fed up to the oscilloscope, the power to the amplifier board, and the bias power supply. On the right side, you can see a separate picture up at the upper right side of the amplifier board and the SIPM, the silicon photomultiplier, here at the green PCB. And below you can see the sodium iodine scintillator. That was 10 by 10 by 10 millimeters in dimensions. With our setup, we made some tests and measurements with an X-ray generator, for which we measured with a QA meters 10 milliseconds pulse width. So it was pulsed X-ray field. Measurements were done in 2 setups. For one was in-beam measurements, where our detector, SIPM detector, and the reference instrument, and the reference instrument was step OD2, integrating ionization chamber, and only the dose, not the dose rate, the dose, total dose was measured. And here is a picture of that setup. Here on the right is our reference detector, and that small detector is our SIPM detector. That was in the other room, the data acquisition room. And here you can see the other setup for measurement of scattered radiation. Here we wanted to simulate some realistic conditions, for example, in hospitals where the X-ray generator is in one room and the control room is the room next to, adjacent room. And we were measuring this scattered radiation in the next room. These oscillograms are showing just a voltage output from the detector, and you can see a lot of things happening. These are on the right side. You can see a zoomed in portion from a few from a few X-ray pulse that were detected. You can see a pulse pile up, noise. There is lots of things happening. This signal was analyzed in a certain root data analysis framework, in which the signal was decoded. DC offset was subtracted, and the signal was conditioned. Signal was then integrated, and to the whole integration of the signal, a calibration from the total dose measured by the reference instrument was applied. This integrated signal was also kept within the time domain, so there was not loss of information. And this integrated signal in the time domain is then, to which calibration was applied, was then derived to obtain the dose rate. So here are results for in-beam radiation measurements. At the upper graph, you can see the dose measurements. Each step is because of the single X-ray radiation pulse. And this data was derived in 1 millisecond window to obtain a dose rate. This gave us a time resolution of 1 millisecond. It demonstrated that our detector has a good enough sensitivity to measure impulsed fields. And we are really happy with this time resolution because it's several orders of magnitude better than commercially available instruments. These are results of scattered.
Luka, please, a little bit, please wrap up.
Okay, sorry. These are results from the scatter radiation measurements. Here we achieved the best dose rate and dose resolution of 1 picosievert and 10 nanosieverts per hour for the dose rate. And we tested the dose rate response and concluded that the detector was suitable for measurements up to 700 millisieverts per hour. And that's mostly it. Thank you.
Okay, thank you, Luka. We don't have much time, so maybe only one question, or you can ask question in chat and Luka will answer later on, to give opportunity for Ivica Prlić to present.
I will place my email in the chat.
Yes, you have one question. Can you clarify the reference instrument and differences between that and yours? From Robert Hayes, but maybe you can or quickly answer until Ivica is opening the presentation, or answer later on by email.
So the reference instrument was the ionization chamber that was capable of measuring total dose, not the dose rate in a certain moment. So this integration ionization chamber was used only to obtain a total dose during the exposure that was used to calibrate the total dose in our measurement. And then this fine, so that fine time resolution is not possible to obtain with the reference instrument, only the whole dose. You can send me an email. I can clarify it further if you want. Please
put your email in the chat. You have one more question and you can answer by email. And we move forward to the presentation from Ivica Prlić. He's a little bit senior researcher with a lot of experience in radiation and medical physics and dosimetry. He is the head of the unit of radiation dosimetry and radiobiology, involved in many national and international projects. He has a lot to say, so I will not present him anymore, and I will give a floor to him to present some information and some data about electronic dosimetric detector systems for time-resolved measurements of pulse ionizing radiation. No, sorry, I read the wrong title. Investigation of space and time-dependent distribution of very low-level scattered X-ray radiation in interventional radiology. Ivica, please unmute yourself. You are muted.
Okay, I think, is it now okay? Everybody
Yes,
can
yes.
hear me. You can see my presentation. Thank you, Željka, for your introduction. I will beg at the beginning for maybe 2 or 3 minutes more because the films, etc., which will be, Lucas told me, 1.5 minutes. I must say that Luka will defend his PhD in the 2 weeks. So I hope that his research will go further, go more, be better, etc., etc. So I will start with some, let's say, it is a strange physical presentation because it will talk and it will give you some input on what the problems we have in measuring the dosimetry in the new medical radiology departments where the new technology and pulse X-ray are introduced. The workers' occupational dosimetry, patient dosimetry, a lot of things are changing on a huge range. So let's start it. First, I will not introduce the title. The title is about time-dependent and scattered low-level radiation. As Marko stated, the melody is keen on the research agenda. On the other hand, the important question is why it is important to investigate the scattered radiation during medical procedures. It is highly important because most of the new modern technology requires that medical doctors are inside the X-ray interventional rooms together with the patients. There are much more therapeutical methods like cardiology. There is a new neurology, interventional neurologic. There are some CT procedures in interventional radiology. So the most collected radiation which can influence on your health, like Marko and Goran said, is mostly from the scattered X-ray radiation from the patient, from the system, from the room, etc. So as it was before 100 years, these X-rays were used to prove something. They were proving something in the shoe shops. What they were proving? They were proving the scientific, this way to approach the problem of do your shoes fit or not. That was a scientific approach. But what was important, they said it eliminates guesswork. It's the same thing today. If you do not have a scientific approach into the dosimetry, then the guesswork will be much lower. And now you can see it for yourself. That is to be, let's say, not only approved, but approved, like everybody's claiming that there are some limits to be exposed to, but let's prove them to ourselves. So that's the new situation. Marko said that there were some left tumors, mostly on the left side of the operator's head, that should be somewhere here. But if the tube is here, but tube is downstairs. So there are a lot of situations where the tube should be. This is an interventional radiology during the catheterization. If you are dealing with the cardiac, the tube will be not here up, but here near you, and there are a lot of other space recombinations of the tubes, so be very careful. What I will be talking about is this piece of equipment in the radiology room. It is a strange machine which is pushing the X-ray to be on, off during the whole procedure. It could be that in 1 hour of the procedure, this will be pushed more than maybe a few times, maybe 10, maybe 20, maybe 100, and that's the dose. So this is the I didn't translate the names on the pictures, so everybody can see what is going on. It's the same thing. That's the experimental arrangement. What was of the interest is how much of the scattered of the primary of any of the X-ray scattered dose will the worker, that was the one of the topics in the Marcos in the second presentation, how much of the scattered dose from the patient, from everything around, the black dots are representing the, let's say, the radiation, just to have it visually. On the other hand, that was the experimental arrangement with the machine, which can be moved all over the space in all of the 3D directions. And here it was a postage of a medical doctor, and then we use it parallel. We did an actual measurements with quite a lot of new developed electronic dosimeters, which are capable to catch the doses in a much smaller time than Luka said, that at least few seconds, because we wanted to try to catch the pulsed radiation from the X-ray machine, which was highly pulsed machine. And then there was a parallel done calculations based on the numerical measurements data. So these are not simulated data, these are calculated. This is a statistical numerical method dealing with the measured data we did on site on more than 50 dosimeters and more than 20, or I think there were 50 procedures. This is the place for one film, but I will go further. I will show you the film at the end of the presentation. These are the machines, the small electronics developed at the Institute. They are now produced as a spin-off of the Institute. They are capable to measure not only the dose, but the dose rate, which was important in our case. As Luka reported the dose, I will report the dose rates. So this is the alternational sound. If you are working in the interventional room, and if you are carrying such a dosimeter will additionally measured. It is a non-stop dosimeter. The dosimeter measures the background radiation and anything else from any field. The dosimeter is brought in. So this will be 8 in the morning, where the work begins, and the first dose will be accumulated. These are the dose rates showing the first accumulated dose by the first procedure. Then a small pause, then a second procedure, then a third procedure, and etc. A lot of procedures are here done. 1, 2, 3, 4, 5, 6, 7, 8 procedures per day, and the dosimeter from the same medical doctor or interventionist will measure at the end total sum of the received dose. Here, some number of the numbers are now not really matter. And if we squeeze out only the first procedure, then you will see here a pattern of dose production of the dose. Each of these barcodes was produced by one push on with the leg on the machine. So there was a huge dose rate here, dose rate here, dose rate here, and everything. So the medical doctor pushed this button down, I don't know, here several times. You can measure it later. But what is important is to introduce what is happening with the background radiation. Dosimeter was, if you can put it just in the room and doing nothing, dosimeter will accumulate. Then you can put the dosimeter somewhere inside the box. It will start to accumulate, but a lower dose because it is closed, let's say, in a drawer. And then after that again outside. It's okay, it's enough. So dosimeter will distinguish all the possible events in the dosimeter room. So in these 2 more minutes, I'll try to stop here sharing with this, and I will open this share if it's possible. And is it possible to see?
Yes.
Do you see the film, everybody? So now
Yes.
this is the results of your computational measurements simulation. What is really happening? I will put it a little bit. Let's say here now it's a field. Then there will be some calculated horizontal dose curves, those slopes. The colors are representing the dose levels. So let's say the blue one is 1 millisievert per minute per hour or per minute, etc. And then I will move it again, and you will see another procedure is the horizontal isodose curves, which are in the same room. So again, the blue one is 1 millisievert per hour. And then if you move the whole result here somewhere, that's now the calculated man, a sort of ellipsoid with the same area as a human skin working there. Then it's again calculations are going on in the horizontal way, in this way. And then at the end, what is most important, I wanted to say, this film represents only the one frozen moment in time. That was the dose in one frozen moment in time. The second dose will be the same movement, and the third dose will be the same movement. And this is now representing from above. That will be try to represent those balloons as the balloons of equal doses in the room every time when the operator squeezes the pedal there downstairs. So this is a frozen moment in time, although you are seeing it as a movable. And at the end, this frozen moment will look like this. Again, scattered radiation, considering, and this is a huge volume representation of volume slides, of volume balloons, one in another, representing those let's say boundaries in the room. So why it is here so squeezed? Because here are the protective equipment of the, and that's and that will be the end of this share. And I will try to share again my presentation. Just why? Because I wanted. Is it okay now? Here no.
Yes, but please wrap up because we are.
No. These are the last 5 images. That's the current
institute. Wrap up because we are at the end of the webinar and people will. We want.
No. You are just losing the time. There are no slides anymore. This is the institute.
All right, maybe we can open it up for a Q&A for a couple of questions before people.
You can open it for the questions. I will show you our dream of a new institute. That's here. And I will show you the current situation. It is from yesterday. So we will hope that the dream will come through. And the dream is here. As Marko said, we are intending to invite everybody of you to the ISoRED conference somewhere.
And as we can see, IMI has very nice, very interesting topics, and I'm sure that in the future, one of the future ISoRED webinars, we will again hear from them. We will organize them to hear what they are doing. Goran and other lecturers shared also the web page of IMI, so you can visit and see in more details what they are doing. I want to thank again to all lecturers for very interesting lectures, and I hope to see you again for the 4th ISoRED webinar. Thank you very much for your participation, for active discussion, and for very good lectures. Thank you and goodbye.
And for the patience.
Bye.
Ciao.
Bye. Thank you, everyone. Bye-bye.
Bye-bye. Thank you.